Okay.
Great. Well, good afternoon, everybody, and thank you for joining us today for our Innovative Discovery Series lecture, which is sponsored by the Delaware Accel Clinical and Translational Research Program. Before we kick off today's presentation, I want to tell you about our next presentation in November. November's Innovative Discovery Series lecture will be on Thursday, November 9th, and there'll be a team of 3 speakers from Northwestern University, and the presentation topic will be an introduction to pragmatic, reproducible research for translational science. So please put that on your calendar. Be on the lookout for an announcement in the coming week regarding Microsoft Teams login information for this presentation on November 9th. Also, for those of you who are interested in CME today, continuing medical education, if you haven't done so already, email Deborah Reese, so she will put you on the list for getting the email for CME, and I think Deborah's going to put her email address in the chat box, so feel free to do that. So great, we're really looking forward to today's presentation for a number of reasons. First of all, it's Health Literacy Month, and what better way of celebrating Health Literacy Month is having a presentation called Health Literacy and its Impact on Surgical Outcomes. That's one reason. The other reason is that we have a guest who is well known to Christiana Care. Our speaker today is Dr. Yarrow Sheldon, who's a surgeon at the Naval Medical Center in Portsmouth, Virginia. Dr. Sheldon graduated from the Uniformed Services University of Health Sciences, and before she began as a general surgeon at the Naval Medical Center in Virginia, she completed her general surgery residency here at Christiana. So welcome back. It's great to see you, and I hope you have a lot of old friends who are coming in to listen to you today. And again, since this is Health Literacy Month, we're really happy to highlight this important issue, and particularly with a member of our surgical team, or a past member of our surgical team. So take it away, Dr. Sheldon.
Thank you so much. I'm very excited. This is a topic I really feel passionately about. Can everyone see my slides?
Yes.
Yes, okay. So first off, I have no financial relationships to disclose, and obviously my opinions are not that of the U.S. Navy. And so we're just going to talk today about health literacy, why it's important, how we assess it in terms of research, and then what we can actually do in the real world when talking to patients. And before we dive into the talk, I wanted to give a little background on why I care about this topic. So in 2021, my father-in-law underwent a large surgery for oral cancer, and his post-operative course was complicated by severe ARDS. And I was the only one in the family with a medical education, and so I was talking to the ICU daily and then relaying updates to my mother-in-law, who has a middle school education. And it was really an eye-opening experience for me in terms of how we as medical providers communicate. And medical terms and concepts, which I really thought were basic, were very easily misunderstood. For example, my mother-in-law thought that an increase on the ventilator to 100% FiO2 was good because 100% is always the best. But really, to me, that was signaling that they were having a very hard time appropriately oxygenating him. And then again, this summer, my grandfather got diagnosed with pancreatic head cancer, which is very complicated and hard to explain even to other medical professionals. And so spending the time trying to help my family understand the roles of the GI, the interventional radiologist, the surgical oncologist, and the oncologist really also just refreshed my mind on how important this is. And then when I was at Christiana in my last year, we have time on the chief service over at Wilmington Hospital, where we act as junior attendings. And over my 6-week time there was a 21% same-day cancellation or no-show rate, which led to a waste of OR time, delayed other patients' care, and prompted me to think about how we can improve our communication with patients to improve their and others' care. So let's start with what health literacy is and its broad effects across the country. There are two types of health literacy, personal and organizational. Personal health literacy is the degree to which individuals have the capacity to obtain, process, and understand health information and services needed to make health decisions. Basically, it's the ability to comprehend and use health information to make appropriate decisions. That will be the main focus of this talk. Organizational health literacy enables patients to find, understand, and use information to make informed decisions, or how hospitals make health information more accessible to their patients. The scope of this problem is huge. It's estimated that over 90 million Americans have inadequate health literacy, which in research translates to about a third of our patient populations having low health literacy. And it's associated with a cost of over $100 billion a year annually in this country. This map is from the UNC, which used data from the 2003 National Assessment of Health Literacy to map health literacy across the country. And you can see the higher rates of low health literacy in the orange and red. In Delaware, approximately 20% of the population have below basic literacy, with higher rates of illiteracy in Kent and Sussex County. In addition, about 10% of the state does not have a high school degree. While the level of education is not directly reflective of health literacy, a low general literacy rate does indicate a higher likelihood of a low health literacy rate as well. So why does it matter? Across all specialties, low health literacy has been linked to an increased risk of emergency care and hospitalization, poor medication adherence due to an inability to understand a prescription label or discharge instructions, increased readmissions, higher mortality, resource misuse, such as presenting frequently to the emergency department instead of their primary care, increased healthcare costs, poorer overall health status, more severe chronic disease, delay in seeking medical help, and delay in prevention and screening care. Basically, patients with low health literacy often delay their preventative care and then present with more serious disease and have difficulty following discharge instructions, which perpetuates that same cycle over again. But as a surgeon, my main job is not to improve patients' chronic disease. What I'm really interested in is how low health literacy relates to surgery and how understanding this can help me improve patients' outcomes. So low health literacy has been linked to patients having difficulty making decisions regarding procedures, difficulty following pre- and post-operative instructions, increased morbidity, and delays in surgery or surgical cancellations. So there are several factors in the recent decades that have exacerbated this problem. There has been a transition from a paternalistic model of medicine to an increased focus on shared decision making. While this allows patients to play a more active role in their care and choose the treatment plan that fits best with their goals. However, if the patient doesn't really understand the choices being presented, making that decision could be a daunting challenge. In addition, patients often turn to the internet for answers, but end up with incorrect information depending on the source or the specificity of their search. The Pew Research Center reports that 35% of US adults go online first to figure out a medical condition, and the WHO reports that there are over 575 million Google results for the word cancer. And this wide availability of potentially inaccurate or non-specific data can make the decision-making much more difficult for patients. There has also been a shift to more ambulatory surgery, which have placed the burden of appropriate preoperative and postoperative care on the patient and their support person. Postoperative care information is usually given verbally to the patient weeks or months in advance and to the support person on the day of surgery, who may or may not remember all the details. Often the patient doesn't see the provider after surgery and may not have the opportunity to ask questions about the discharge instructions once they've got instructions may be above their health literacy or even just literacy level. So before we dive into the surgical studies on health literacy, I wanted to spend a little time reviewing the most frequently used and validated tools in research to assess a patient's health literacy so that we can understand how patients are being categorized in the research. I'll review the test of functional health literacy, the rapid assessment of adult literacy, the short assessment of health literacy, the newest vital sign, and the brief health literacy screen. So the test of functional health literacy is a test of functional health literacy, which is a timed reading comprehension test, and it's presented as a fill-in-the-blank format that you could see on the left. The full length takes 22 minutes and has 50 reading comprehension questions and 17 math questions. And the short version takes 7 minutes with 2 passages. The rapid estimate uses pronunciation to estimate reading level and therefore health literacy. While the test checks pronunciation, it does not check reading comprehension or numeracy. So if the patient has heard these terms before, especially with the subspecialty versions of the test, it can skew the results. But it's very quick, only takes 5 minutes, and has been shown to correlate with health literacy levels. The short assessments of the health literacy tests pronunciation and comprehension by requiring that the patient pick the term with the closest association to the first word. A correct answer requires both correct pronunciation and association. The test is quick, taking only 3 minutes, and low health literacy is predicted by a score of less than 14. The newest vital sign was developed by Pfizer and asks questions about an ice cream nutrition label. It's very different than the other ones in that it tests the patient's literacy, numeracy, ability to interpret presented data, and decision making. It takes 3 minutes, and the score of less than 3 indicates the possibility or high likelihood of low health literacy. And by testing the ability to interpret presented data, this test can help show if the patient's able to process presented information and then use it to make informed decisions. The brief health literacy screener is a very quick test with either 3 or 4 questions to help determine a patient's health literacy level. It is different from the previous tests in that it doesn't test pronunciation or comprehension, but rather relies on patients to self-report their ability to understand their medical conditions and medical materials. A score of 12 or less will have difficulty understanding instructions and may need repeated instruction as well as visually presented information. This test requires that patients self-report accurately, which can make the results inaccurate. As you can see, all of these tests have strengths and weaknesses, but it's important to keep in mind that they're not used clinically, but as a way to identify this population in research trials. So before we dive into the impact of low health literacy on surgical outcomes, let's briefly review patient characteristics associated with low health literacy. In general, it's associated with older age, less education, lower socioeconomic status, uninsured, poor English skills, and multiple or poorly controlled comorbidities. Low health literacy affects all aspects of the surgical course, even starting with the decision to have surgery. Low health literacy has been associated with a higher rate of decision conflict, leading to poor shared decision-making with their surgeon. Decision conflict is not improved by presenting patients risk assessments, such as the NSQIP calculator, as these tools can be difficult and overwhelming for patients to understand. Patients with low health literacy may not understand chronic or non-life-threatening conditions and therefore delay preventative care. it can be hard to take something seriously if you feel well and don't have any symptoms. This can be seen with decreased presentation for colorectal screening in patients with low health literacy. These patients also appear to have a decreased rate of referral to the renal transplant list, likely due to perceived poor compliance with their end-stage renal disease treatment. Another study, which examined emergency surgery for diverticulitis, showed a higher rate for non-English primary language speakers, with even higher odds if the primary language was not Spanish. This correlates with the association of delay in care for low health literacy patients. And while language barrier is not the same as low health literacy, it likely results in the same problem where the patient does not fully understand the disease or condition. Once a decision is made to have surgery, patients are often given a list of instructions, including diet modifications, medications to hold or start, and even when to show up at the hospital. Patients with low health literacy have been shown to have increased rates of non-adherence with preoperative medication changes, but the health literacy doesn't appear to affect preoperative fasting, likely because this can be explained very clearly. One study created a surgical site infection prevention kit for all elective colectomies. This was provided for free to all patients and included a carbohydrate drink, bowel prep, chlorhexidine, instruction sheet, and a link to an instructional video. And providing this kit led to an increased rate of bowel prep adherence. In a study with 1,200 patients, those with low health literacy were found to have a longer length of stay after major abdominal surgeries. In another study, low health literacy patients after general, vascular, and thoracic surgeries at 4 VA hospitals were found to have higher readmission rates and higher post-discharge complication rates. Another study following the 5-year after ERAS protocol was introduced demonstrated that low health literacy patients presenting for elective colorectal surgery had a higher rate of conversion to open procedures, higher incidence of surgical site infection, deep space infections, and longer lengths of stay. In the study which provided the surgical site infection prevention kits, there were marked improvements, including lower rates of prolonged ileus, lower rates of surgical site infection, anastomotic leak, shorter hospital stays, and fewer readmissions. This was all accomplished by providing free preoperative materials with instructions in 2 different learning styles, written and video. And this appeared to give higher compliance rates in the low health literacy population. Another 2 years prospective study examined 900 patients on an emergency general surgery service who required surgery. The low health literacy patients were more likely to have longer hospital stays, higher rates of 30-day complications, and 30-day readmission rates. They were also less likely to discharge home, had a longer time to resume their activities of daily living, and had lower medication, wound, and drain compliance rates. The authors found that low health literacy emergency general surgery patients are often at higher risk of poor postoperative outcomes, likely because of the need to make quick decisions, often with a large multidisciplinary team with frequent personnel changes. There is also an element of stigma, shame, or even unawareness of their own low health literacy, setting patients up for a situation where they receive a lot of information in a quick, sometimes disjointed fashion that they cannot process, but are expected to make appropriate medical decisions in line with their life goals. Patients with low health literacy can have a hard time comprehending discharge instructions, though this does not appear to be correlated with education level. There is also a correlation between treatment compliance and low health literacy. Specifically, it's been shown that breast cancer patients with lower health literacy have less multidisciplinary team participation, more missed appointments, less perceived shared decision-making, greater fear of cancer progression and recurrence, but also lower medication adherence rates, including hormone therapy and immunotherapy. This is also seen in renal transplant patients, where low health literacy is associated with higher postoperative creatinine. So now that we've reviewed the multitude of ways that low health literacy can negatively impact our patients, what can we do to improve our communication and outcomes once we identify these patients? So this video, from Christiana illustrates, illustrates the importance of clear communication with our patients and the awareness of the medical terminology that we may use without realizing how incomprehensible it can be.
Dr. Sheldon, you may need to reshare and select the share audio button.
Okay. Let's see. Okay. Let me know if you can hear it now.
Your patient and family health education team would like to wish you a happy Health Literacy Month. Let's take a peek at this week's Health Literacy Short.
Hey, Mrs. Literacy. It looks like you have acute bronchitis. We'll have to keep you here a few more days.
Hey, Mrs. Literacy. So sorry to see you're back in the hospital. How has your care been so far?
You won't believe this, but one of those young doctors was flirting with me. I don't know what a bronchitis is, but that young man said I had a cute one.
So, what can we learn from Mrs. Literacy? Use plain language. Avoid medical jargon. And define terms if you must use them to help ensure your patients understand and to avoid having awkward conversations like these.
For more information on how to improve the understanding of patients and families, visit the
So I really enjoyed that video for two reasons. One, because it makes me laugh a little bit. And two, because we used to, like, acute to me I don't remember that it's a term that people don't use on a regular basis. And so things that are so ingrained and fundamental in my daily language, like acute or chronic, are things that patients won't understand and can easily be misunderstood. And so patients often aren't aware of their health literacy status. There's no score that people are given that makes them know how much they do or do not understand about their own bodies. And when talking with a patient, it's important to explain the why to make sure that patients understand what you're recommending and why it's important for their health. So in explaining, it's also very important to avoid medical terms like we just discussed and acronyms. And while it sounds obvious, having that reminder, because words that you use on a daily basis may not be words that the patient has ever heard before. And there are several online medical dictionaries, such as this screenshot, which is from the University of Michigan, which can help translate medical words to more simple terms. So when you're talking to patients, really keeping in mind that you should stick with 2 or 3 key points and then repeating those to make sure the patient understands. And speaking slowly with short sentences and short words. And at the end of the visit, instead of asking, "Do you have any questions?" you can ask, "What questions do you have?" which is much more open-ended so that the patient might feel more comfortable bringing up concerns. If there's a caregiver in the appointment, also making sure that they are comfortable with the information and that they also have had the opportunity to ask any questions. Patients can forget up to half of what they hear in an often visit, so it's good sometimes to have that second person there because that helps remember everything that you've discussed. So another important tool in making sure that low health literacy patients understand is teachback. And this is a method that I think lots of you have probably heard about. But at its core, it's really a way to have the patient repeat back to you in their own words what they understand from what you've just explained to them. And it's important when asking the patient to make sure that you start the conversation in a non-confrontational manner with open-ended questions and plain language, so that they don't feel judged or like they're being quizzed or tested on the things you just told them. So you could start the conversation with phrases like, just to be safe, or I want to make sure I explain things clearly, sort of putting the burden on you. And there's this video that I think also does a great job of showing why it's important to use teachback.
Hello, fellow educators. Your Patient and Family Health Education team would like to wish you a happy Health Literacy Month. Let's take a peek at this week's Health Literacy Short.
His blood glucose log is still showing he's been running high even after starting insulin. Can you put an orange in the room? I'll use it to show him how to inject his insulin again. I think he needs some reteaching. It's good to see you again. We started you on insulin the last time you were here. How has that been going?
Good, but boy am I tired of oranges. Can I use something else? Maybe an apple or a peach?
Can you explain to me in your own words how you give yourself insulin?
Oh yeah, I do it just like you showed me. I get my pen ready, and then I put it into the orange. Press down to put the medicine in, and then I eat it.
It looks like someone forgot to do teachback during the last visit to make sure our patient knew how to take his insulin properly. Mix-ups like these can be detrimental to the health of our patients. So always use teachback by asking the patient or family member to explain information back in their own words. Or ask them to show you. Use open-ended questions and a caring tone and posture. Confirm if they are able to teach back. If not, try explaining again and recheck with teachback.
So another tool that we in surgery often use when discussing post-operative risks involved with surgery, especially with an emergency surgery, is the NSQIP calculator, which was developed by the American College of Surgeons. And this can be an invaluable tool, but it's worth taking a look at it through the eyes of a 3rd grade or 6th grade reading level. The terms used to describe the majority of these categories are above a low health literacy patient's comprehension. And while the colors make it easy to see if your overall risk is green, yellow, or red, there are a lot of words in the diagram, many of which, like thromboembolism, pneumonia, or delirium, may be incomprehensible to the patient. In addition, percents can be hard to understand, and presenting this data as an array can make it more accessible. So if you say 7 out of 10 patients in your situation instead of 70%, a patient with low health literacy might understand their risk better. It's important to use a calculator as a tool to help explain the situation, but not allow it to become just more incomprehensible and overwhelming information to an already stressful situation. So in an effort to avoid same-day cancellations or no-shows, it's important to make surgical scheduling a collaboration with the patient. There was a small study that looked at organizing the surgery and anesthesia preoperative evaluation, as well as any lab work, all on the same day in the same location. And the patient would pick their own surgery day while in the office, and then would get a phone call 2 days prior to surgery to help ensure that the patient was still in good health and still planning to present for their operation. If they were unable to follow through with the surgery, the 2-day window allowed enough time to schedule another patient at the slot. And these adjustments allowed for a better patient experience and made the patient easier to navigate. But this was such a small study that they didn't really show any clinical significant changes. The patient's understanding of their discharge instructions is very important, as this is their sole source of information until seen for post-op check. While before surgery, friends, family, and the internet are often the patient's most trusted resource. After surgery, it's their discharge instructions. It can also be helpful to discuss how to identify reliable health information online. This poster from the NIH stresses identifying the author of the page, any bias, and if the information is correct. However, this level of critical analysis may be beyond the ability of a low health literacy patient. If they're having an ambulatory surgery, the discharge instructions may be given to their support person verbally, but the patient will only be given verbal instructions preoperatively and their discharge instructions. Therefore, it is very, very important to make their discharge instructions as clearly understandable as possible. While it is important to include activity and diet restrictions on the discharge paperwork, it is also equally as important to include reasons to call the office or present to the emergency room so that any postoperative complications can be identified quickly. A study which standardized discharge instructions for patients who underwent creation of hemodialysis access used clear and simple terms like cuts instead of incisions and Tylenol instead of acetaminophen, as well as clear reasons why to call the office or to present to the emergency room. And these changes help to reduce the bounce back rate to the emergency department, as well as a delay in seeing the postoperative complications. So in the discharge instructions, they should ideally be readable to 3rd grade level, and they should be written in an active voice using specific directions. So instead of saying regularly, you say 3 times a day, using a large font, double spacing so it's easy to read, and then using bold or bigger type to highlight important information. And medical art should be friendly and simplistic, but not realistic. So this is an example of standard discharge instructions for an appendectomy. You could see they use simple drawings, so it's clear to see where your appendix lives, and bold headings with bullet points, which are all good things that make things easier for the patients to read. But there are still longer sentences, only the one picture, and a lot of words on the page, some of which are longer, like recover or strenuous. And in addition, it's important for providers to review the standardized discharge instructions because they might not align with what you have told the patient, which can lead to conflicting information and confuse the patient and their family. And there is a video before we start the slide.
Asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes. Anna, you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
So as that video illustrates, it's very important to clearly explain to patients how you want them to take their medications. It's also very important to be clear on your discharge instructions about any new medications. And one study showed that 63% of patients with low health literacy had a hard time understanding the prescription label, including terms like orally, dose, or antibiotic. In addition, the low health literacy patients had difficult times understanding the instructions when there were more than 2 numbers in the sentence. So, for example, saying take 2 tabs twice a day was confusing because of the different numbers in there. So you really want to work on keeping all the discharge instructions as simple and clear as possible to try and increase compliance. So I want to end this talk by discussing, at least for me, what resources I've been using and how to find them. And so the American College of Surgeons has a webpage for patient education, and they have handouts for basic surgical general surgery procedures. So this is the first page of their appendectomy one. And it does a nice job of going through what the condition is, what the surgery is, what the highest frequency of complications are, and explaining them in pretty basic terms. And so if I have a patient coming in that I'm booking for a surgery, I'll usually have printed out their handout and then talk to the patient, but also go through the handout with them. And this way I know that if they have questions and are going on the internet, at least I've pointed them to a reputable source. And by going through it with them, even if all the terms are not in their health literacy range, I've at least explained most of them so it can be understandable. I often will also draw pictures for patients in terms of what the anatomy that we're discussing is, because unless you regularly operate on someone's gallbladder, you might not understand where it is in relation to the liver and the bile ducts, and making that simple line drawing that patients can then take home with them can make things much more understandable when we're having that conversation in terms of informed consent and making sure that they actually understand what I'm saying. And then also, if I'm giving patients more than 3 to-dos, like I want them to see another provider, I want them to get labs, I want them to get imaging, I write them all down because I don't want them to forget, and it shouldn't be solely on their responsibility to remember everything I'm telling them. So in summary, I think there's still a lot of work to do. Most of it is in recognizing patients' low health literacy and then keeping it in the forefront of your mind so that you can tailor your discussion so that the patient can actually understand you and we can provide the best care, which is really what all of this is about. And so does anyone have any questions?
Well, I think I'll start. Thank you so much first. It was a wonderful presentation and very, very informative. And I really wish that all physicians use the same tools as you presented. And in fact, I was wondering about so you have these tools for pre-op that you just showed, for example, for appendectomy that you use with your patients. And so for discharge, discharge guidelines or discharge instructions that you give to your patients, do you have also standardized tools that you have either done yourself or made yourself or found on within the professional organizations?
So at Christiana, there are standardized discharge instructions. So like anytime someone has an appendectomy at Christiana, they get that same standardized discharge instructions. And it's pretty nice because they're translated into lots of different languages. So if you have a patient where Spanish is their primary language, you can give them the Spanish appendectomy discharge instructions. And because you can see the English ones, you have a general idea of what they're saying in the Spanish ones. I do have a little template that I stick in my discharges, sort of things in clear terms that I like to just highlight because, the discharge instructions will be 5 to 8 pages long. And I'm not sure if patients actually read all of it. And so this way I've sort of given like the highlight bullet points of what I want them to do when they go home. I was actually, just a little side note, so my grandfather was diagnosed with pancreatic head cancer, and for me, for my patients, I've always said, for pain, you do Tylenol and you do Motrin, and then you alternate them every 4 hours. And he had a really difficult time doing the scheduling of alternating medications every 4 hours, which to me seemed, very basic. But now I've kind of rethought how I tell patients to take their to take their pain control medications, because I think that things that even sound easy when you tell a patient to do it a certain way can actually be very tricky, especially if they're older.
Oh, that sounds great. Any questions from the audience? In the chat.
Hey there, I'll jump in. Dr. Sheldon, this is Greg O'Neill, the Director of Patient and Family Health Education at Christiana. We are so excited that you came back. You're officially, with 2 presentations, nominated to the Health Literacy Hall of Fame here at Christiana, so thank you. Really, really happy to have this presentation available to everyone. I just wanted to say happy Health Literacy Month to everyone. Hopefully you've encountered our calendar of events. We've had things happening all month. 2 things I wanted to share with you. This group might be interested in a health literacy conference that is actually happening at the end of the month. I'll put the link in the chat, but it's a 2-day virtual conference, Health Literacy Annual Research Conference. So you can see what other places are doing in terms of health literacy research. It's a really wonderful conference. The other thing I'll say is that next Monday, we're actually going to the governor's office. We were successful in our application to get October recognized as Health Literacy Month with a proclamation. So we're pretty excited to see that. And this topic is becoming, more important to the way we provide care. So just wanted to thank you, Dr. Sheldon, again, and thanks everybody for attending today.
And so, a question for you, Greg: are all the are they standardized form for all kinds of surgeries and everything set up at Christiana for health literacy purposes, pre and post surgery?
Yeah,
or post procedures.
We partner with HealthWise, who is our vendor for patient education content. So that's available on the .org website. It's available through the medical record, through the EHR, as well as through our marketing team and our care management folks. We try to have that one vendor content be available system-wide in all points of contact. The library for that content is around 8,000 different topics. So they do have a ton of content, both video and text-based. And they may not have every single topic under the sun. There may be some gaps and things like that we have to try to fill. But in general, they're going to have most of that pre and post surgical content.
That's great. That's really good news.
Yeah.
Christiana also has this really great tool on their website where if you're trying to help patients decide between 2 surgeries, so like if you have breast cancer and you want to decide between breast conserving therapy or a mastectomy, there's like a little calculator that patients can do at home, and it asks them a bunch of questions and then tells them which surgery lines up more with their goals and gives them a review of the surgeries. And I really loved that tool. I thought that was great.
Which website is this?
This is right on the christianacare.org website.
Okay.
If you go to our health library from the main page, you can get to all the content, the videos, and the shared decision-making tools.
Mm-hmm.
Okay, that's great. All right.
Thank you so much for having me. It was nice to give the talk again.
Thank you so much. That was great. And
Thank
great
you.
to see you.
Yeah, it's nice to see you.